Good morning, dear friends. It's a great pleasure to be in Rajkot. In fact, my very close friend and cardiologist, echocardiographer, Dr. Rajendra Goyal used to visit Rajkot very frequently in 90s and I think about 20, 30 years back. He used to talk very highly about the hospitality of Rajkot. And I'm very pleased to experience that yesterday with good Kathiawadi dinner also outside. Thank you, JB Chemical Company also. All right. So, dear friends, we heard a lot about hypertension, the resistant hypertension, various guidelines. Now, both the speakers highlighted about cilnidipine, the calcium blocker, the fourth generation calcium channel blocker. So, this talk is more focused towards cilnidipine in this particular case, and especially this is a case which we will be seeing more often because most of the guidelines were formed with earlier literature with elderly hypertensives, and we have more often the young hypertensives in our scenario. So, who want to overdrive to reach the target very fast, overdrive, overloaded, and who have high sympathetic triggers in young Indian hypertensive. So that is our typical population. And these people do not, many of them do not know, as Kapil Bhai was talking about, silent hypertension and silent killer. So many of them are enjoying with kids, with families, and then they have never checked their blood pressure, and hypertension harbors silently. And this is a relatively old paper of 2014, about 11 years back, by Raghupati Anchala, which showed that the awareness, treatment, and control, which even Dr. Srenik was showing in his slides, it is very less. But then he said in USA about 55% are uncontrolled. But then here we have even worse scenario, which you'll see in one of the subsequent slides. Now, stress is the cause for young hypertensives, but what is this stress? I mean, is it dil ka dhak dhak? No, I mean, dhak dhak can be like this, a party, or it can be like some film star. I used to see in my daughter's room, I mean, there were three big posters of three Khans, Shah Rukh Khan, Salman Khan, Saif Ali Khan, till I think 98, 99, Leonardo DiCaprio was replaced by all these Khans. So it's not that, it's not the cricket match. This is a momentary excitement. But what is really harming our generation, young generation, is this kind of stress, which even you saw the Dr. Srenik was presenting this medical representative Rakesh with 42 years and having extreme stress and then targets and all the time they are busy trying to fulfill the requirement of the superiors. And then that has led to a study, and which was published in India Today, and it had said that 80% of the people are stressed. And then I have seen that. I mean, even the small child. I remember my daughter when she was she was in the kindergarten, and on the toilet seat she was trying to remember brinjal, banana, bangan, and like something which I think she must have been told by the teacher that tomorrow I want all this list to be this thing enumerated, and then they are always worried that what will happen if I don't say that during parent-teacher meeting. My parents will be humiliated. They will come and they will slap me at home. So that is the kind of stress right from the kindergarten, then to the school, then getting into the career-oriented course, and then the sitting in the practice. So that kind of stress is there. And that leads to this very unhealthy behavior with smoking and alcohol, coffee, and then sleepless nights, and whatever this medical representative Rakesh was also doing. And that leads to this high incidence of hypertension. And this, Dr. Kapil also said earlier that 1 in 3 Indians are hypertensive. This is a National Family Health Survey 5, which was again throughout the country it was done. And ICMR, Indian Council of Medical Research, India Diab study also both summarizing both these things. 33% are hypertensive. As opposed to that, in Western countries, it's about 25%. And then so also about diabetes, and then pre-hypertension. It is pre-hypertension, which just in the previous lecture you heard that it should not be called pre-hypertension, it should be called as elevated BP. So, which should be included in the hypertension also. And most often, the small rise in blood pressure, it is ignored. But is it beneficial to reduce even small amount of BP. This is an excellent study. This is a seminal paper by Levington et al. In Lancet 2002, where almost 12.7 million person years with 61 observational prospective studies were involved. And it showed just 2 millimeter reduction in the systolic blood pressure. It will reduce 7% ISD death rate and 10% stroke death rate. And that's why it is very essential to reduce it. But at that time, Cruikshank came into picture, and then he said there is a J-shaped curve. So if you reduce it too low, it can be harmful. But in 1998, this Lennart Hansen, he came out with his HOT study, and he showed that you can go to the absolute low. And then he was all his life, he was busy promoting his concept, lowest is the best for blood pressure, lowest is the best. In fact, in 98 he published this, and unfortunately died in 2002. He did not live to see the impact of changing guidelines where lower blood pressure was introduced. Even 1 week before he died, he was trying to promote this when he knew that he had cancer, which he had not revealed to anybody. That was Lennart Hansen, the principal investigator of HOT study. But Cruikshank at that time did congratulated Lennart Hansen that the 12-year-old controversy is over now, there is no J curve, and then we are getting benefited. But unfortunately, again coming back to this NCD monitoring survey of India, that out of the 100 people who are hypertensive, how many are aware, how many are taking treatment, and finally only 12% are under control, as opposed to what Dr. Srenik was saying, 55 in USA, it's 12% in India. For length of time, the drugs which was used for hypertension control was beta blocker and diuretic. JNC1, JNC2, JNC3, up to JNC5, everywhere. Till 2005, this Lindon's meta-analysis came, and it showed beta blockers increase the stroke rate by 13%. It's not that beta blocker produced stroke, but the other drugs reduced the stroke to such an extent that the difference between people taking other medicines versus beta blocker was worse in beta blocker group by 13%. And subsequently, even that was in 2005, Lindnom's meta-analysis, and 4 years later, even BMJ meta-analysis of more number of trials with 47. There also you will see the beta blocker versus any other drug in the forest plot graph. You will see, 1 minute, can I start the pointer? Yeah, in the forest plot graph, you can see the beta blocker had again 18% increase stroke rate. Initially, when it was thought that just reducing the blood pressure is important, any drug is good enough. Because all had showed whether you use calcium blocker, whether you use ACE inhibitor, whether you use any drug, just the end results are the same. But for the first time, accomplished study, which came 2008, that showed that there is a difference. In addition to angiotensin receptor blocker, if you use diuretic versus calcium channel blocker, the lower curve is for the blue curve is for calcium blocker, and the mortality is reduced. Subsequently, there was a Camelot study which showed that amlodipine, the calcium blocker, also reduced the atheroma volume. That is still, I think there is no other study replicating with calcium blocker, but there was a reduction in the atheroma volume, the plaque volume in the carotid. So that was one study. The left ventricular hypertrophy also, if you see the different drugs which reduce it, the beta blocker, then diuretic, then ACE inhibitor, and then CCBs are second from the top, and then the highest is of course ARB. And then that is probably because of the LIFE trial which came in 2002. But then in LIFE trial, what was done is they had taken basically those patients who had LVH to begin with proved on ECG, Sokolov-Lyon criteria. So those were the people who had extremely high left ventricular mass. They had abnormal angiotensin gene, and these are the people in whom the losartan was successful. So maybe that trial was little biased, the trial design was biased, the selection was for specifically with severely hypertensive people. So, but then after that, of course, the ARBs have remained on the top, CCBs are on the second if you want to reduce the blood pressure. But it's not just one drug which you should consider. because there are different mechanisms. The hypertension is multifactorial, and then one patient may be having sympathetic nervous system, second it may be having RAS excess, renin-angiotensin excess, and third it may be just the excess salt intake, like what we heard in the previous lecture, and then producing water logging. So that brings us to this case discussion. This is Suresh Bhai, 38-year-old, just like our previous medical representative. He's workaholic, we don't say workaholic, targetoholic, and then they have the targets till the end of this month. They have to produce this, and their sales should be this, or that should be done. So his complaint was just little palpitation and mild headache, not aware that he had blood pressure. Then upon probing, he talked about his lifestyle was sedentary. He was going, never ever went to the gym, a very stressful job, and screen time all the time on computer. Even at night he would be with the computer or with his mobile, unable to sleep, and then frequent outside food also. I think many executives are like this, and then all the time they are stressed, as you can see here, and then that had led to this India Times paper also, that 80% of Indians are under stress, increased screen time, and sympathetic drive. So this is a typical picture with screen time, and then which increases cross-sectional study in India, which showed that they have hypertension and then sympathetic drive. How do you prove that these people have sympathetic drive? One simple thing is to look at the pulse rate. But then if you want to do a research work, then you can always see the plasma norepinephrine level, which is secreted from the adrenal gland, and or maybe the renal, what you can see, a renal noradrenergic spillover, which you can see. But then of course we are not researchers, and in our patients we are never going to do it. But still, if you want to see whether there is sympathetic overactivity or not, there is one simple test of this sympathetic nerve, the muscle sympathetic nerve activity. One simple probe, just like our EEG probe and this thing, that it will give the muscle sympathetic nerve activity increase. And as you can see here on the left hand side, with the controls versus hypertensives versus with multiple risk factors, how the sympathetic nerve activity is increasing. It's very simple, and clinically, of course, you see the patient is nervous, he's panic, he's anxious, he doesn't sleep well, he has palpitation, he has high resting heart rate, and then along with that he has increased sugar because of all the stress hormones are they produce rich sugar also. And this thing, generally stress, has multi-organ effect with heart, brain, and then blood pressure, and then the renal damage also. It's a vicious cycle. So this particular Suresh Bhai had blood pressure of 160 or 90 with heart rate of 98. Definitely high sympathetic drive person with HbA1c of 7, obviously with his no gym, no activity, and then all the time eating outside. And then not only that, but with this 160 over 95, we call it stage 2 hypertension as on today. And then stage 2, or even with the latest definition, it will go to stage 3. Earlier it was stage 2. And then he had, as a result of that, left ventricular hypertrophy also. So you further evaluate him. If you have a fundoscope, then one can do fundoscopy. But obviously we always do sugar monitoring, lipid monitoring, and to see if you are, after echocardiography, if you suspect even carotid intima media thickness, to see the patient. And in this patient, our target should not be just controlling the blood pressure, because blood pressure is just a mere number. I mean, this is all the target organs are already affected. You have to look at the different targets. So if you just treat the blood pressure, then it will be only 1/8 of the iceberg which you are treating, and rest of the 7/8 will be unattended, untreated, which will have its subsequent effect and all these multiple organs like brain, heart, kidney, producing its target organ damage. So in India, about 35% of the hypertensive patients have renal target organ effect, and that also under 45. and that is in the form of microalbuminuria. And then that's why you heard in the current guidelines, especially in Indian guidelines, you heard in the previous lecture, they have included microalbuminuria should be included in each and every diabetic, each and every hypertensive patient, and it can be included even in the annual health checkup, medical health checkup also. And to attain all this, you have to see that his blood pressure is less than 130/80, heart rate remains on the lower side, left ventricular hypertrophy is there. You select the drug which is more friendly towards reduction of the high blood pressure, and use a drug, select a drug which will protect all the organs. Left ventricular hypertrophy, of course, all of us take ECG in our clinic as a primary investigation, but echocardiography is also extremely common, and left ventricular mass and mass index would be two things. And LVH, just the mere presence of LVH, look at this Kaplan-Meier curve, the LVH and then survival curve, how different it is with LVH present versus LVH different. So that's a bad news, but what is the good news? So if this LVH concentric remodeling becomes evident hypertrophy, then the mortality is increasing. As opposed to that, if it is regression of left ventricular hypertrophy, which we saw the top two medicines were ARBs and then CCBs, then in the Kaplan-Meier curve you can see the hazard ratio is decreasing. So you have to take care of the LVH. You should not be using these drugs which increase LVH, like hydralazine, which used to increase left ventricular hypertrophy. But as opposed to that, ARBs and CCBs reduce this thing. Left ventricular hypertrophy. So in this particular patient who already has hypertension, who has sympathetic overdrive, and he has already cardiovascular involvement in the form of left ventricular hypertrophy, he has diabetes, and he has also albuminuria. So these are the things, sympathetic overdrive, you have to treat. The first is, of course, lifestyle management. Lifestyle management is very easy to say, but very difficult to follow, but still we have to tell them that this is extremely important: yoga, meditation, and then avoid all these PPPs, the packaged, preserved and processed food. So all of them have a lot of salt to increase the shelf life, and then papad, pickle. So all P's are there in this. And this lifestyle modification will help in all these things which were going in the wrong direction in this particular patient. He will have better sleep, stress management will be there, he will go for recreational activities, so on and so forth, and which will help in achieving this. The second important, I think, today's discussion topic was about the CCB, especially cilnidipine in focus. So calcium blockers, no doubt that they reduce the calcium entry into the myocardial cell, not myocardial, vascular smooth muscle cell, and then they prevent the contraction, made it relaxed, and then with vasorelaxation the blood pressure comes down. That is the thing. But then cilnidipine has certain special thing, and then that's why there are so many trials which you can see, which came one after the other to prove its benefit. What's so special? Because these calcium channel blockers, dihydropyridine calcium channel blockers, which you saw that they block the L channel and prevent the calcium entry into the smooth muscles and produce vasorelaxation. But this L and N blocker, cilnidipine, blocks also the N channel, and then this adrenergic release is prevented, and all these subsequent effects on the vessel, heart, kidney, etc. are prevented with that. As you can see here, this adrenaline producing, the norepinephrine producing all its effect, including stroke, myocardial infarction, angina, cardiac failure, congestive heart failure, so on and so forth. And amongst calcium blockers, if you compare that, is there any real stuff in what we say? That this is a real example with Akira Takahara's paper is very commonly quoted, that nifedipine, which was the first entrant in 1980s in India, that it does increase the heart rate which we had seen. But in 93, certainly the Furberg presented a paper which saying that nifedipine increases the heart attack rate. And that is basically because of acute vasodilatation. There is a reflex sympathoadrenal activation, and then adrenaline coming in, producing tachycardia, plaque rupture, and then platelet aggregability, and stroke and myocardial infarction was the thing. And as you can see here, this there is a norepinephrine level, and then with this nifedipine, this is heart rate, and if you see the BP is reduced, but at the same time norepinephrine and sympathetic drive is increased. As opposed to that cilnidipine, there is a very flat curve. The BP is reduced, but there is a flat curve. Even benidipine, amlodipine are not matching with cilnidipine. Even the left ventricular mass index gets reduced, as you can see here in this particular paper, which had come way back in 2013. And then this is a candle study, was very elegant study, which showed the left atrial volume index also reduces, which I think majority of, I mean, currently if you say the heart failure is one epidemic, atrial fibrillation is second epidemic. And left atrial enlargement leads to atrial fibrillation, but LA volume index reduces. That is what was proved in the candle trial in this, as you can see here. And then left atrial volume index was also reduced. Now this is a very commonly quoted study on cilnidipine, and that is Achieve-1, in which almost 2,319 patients were done, and then 70% people were given cilnidipine just one dose. Many times people say that cilnidipine half-life is 10 hours, 12 hours. Should we give it twice a day? But no, in this particular Achieve-1, then this Kazuhimo Karyo had in 70% people he had given just one single dose in the morning, and as you can see here, the morning BP, excellent reduction. But then more importantly, if the BP is very high, the BP reduction was very high. If the heart rate is very high, heart rate reduction was very good. But if the baseline heart rate is 60, it wouldn't get reduced significantly, as you can see here. So very gentle reduction in the mild hypertensives and mild and who do not have very high heart rate. Renal protection. As you can see here, this is a renal protection which is seen. I'll just 30 seconds remaining. I'll just quickly go through this. That there is a renal protection, and then it is said that it gives rise to the podocyte protection in the form of this podocin and nephrin, etc. And then which was proved not just in theory but in tactical study, the albuminuria as opposed to amlodipine. As you can see on the left hand side, it is reduced. And even the renal interstitial damage, which leads to this liver fatty acid binding protein or oxidative stress in the kidney. So those also been amlodipine, you can see it is increased, proteinuria was increased, as opposed to that this injury and these indicators were reduced with cilnidipine. And so this way the patient will get protection of heart, he will get protection of kidney, and then last but not the least, the cerebrovascular protection. Just maybe half a minute more. This Wattenby had shown that cerebral blood flow, which is auto-regulated. The moment you reduce the blood pressure, they may be, especially if there is a below the threshold, if you go, that was shown by Steingart et al. In 1986. So if you reduce the blood pressure too low, then cerebral blood flow will be reduced. But in this Wattenby's paper, it was shown that cerebral blood flow was maintained regardless of the decrease in the blood pressure with cilnidipine. But of course, still that Steingart's lowered the limit. So I think that covers everything. And just the last maybe 20 seconds for one addition of bisoprolol, because all that earlier Lindholm's meta-analysis was showing that there is increased 13% and 16%, but then the 2009 meta-analysis showing 18% increase in the stroke rate. But all these trials had atenolol, as you can see. Few had metoprolol. None of them had really this dual calcium channel blockers, and then not the recent vasodilatory beta blockers also. So this vasodilatory blocker or this super selective beta blocker, bisoprolol. Why I am saying this? Because I think JB Chemical is trying to bring a combination of cilnidipine with bisoprolol. So just the second last slide of mine is about this bisoprolol. So most often we are worried with beta blockers about this asthmatic patient, COPD patient, his bronchospasm will get aggravated. But as you can see here with atenolol, the airway resistance, and with bisoprolol. So how this thing, it is minimally affected by bisoprolol and not by this thing. And second important side effect of beta blocker is always talked about in these young people about sexual dysfunction, and even the erectile dysfunction, sexual dysfunction. If you see the placebo enalapril amlodipine versus bisoprolol, bisoprolol has again is even less than placebo this thing effect. So our patient would get this thing, lipid profile, then KFT, LFT, thyroid profile. He will get cilnidipine plus one ARB because he has left ventricular hypertrophy. Beta blocker, if we have to add because of his 90 plus heart rate, then bisoprolol will be a good addition. And then of course for his HbA1c, if it requires, then obviously the current generation disease modifying and the heart protective, cardiac CVOT protective newer anti-diabetic medicines will be given. And above all, actually it is in the lowest in the table, but above all is lifestyle modification. Thank you very much for the kind deal.